The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So hi guys, so welcome back to our another set of topics sa pharmacology. We have your antibacterial. So this will be the last topic that I will be discussing under pharmacology. Actually, ang antibacterials natin and lahat ng mga antimicrobials natin, they're one of the parang most challenging then to study, Kaya I don't want to overwhelm you with a lot of information in this lecture. I just want to really give a parang basic background and ano yung mga kailangan yung tandaan and more of mapakita kung ano yung overview ng lahat-lahat, Pero I want this to be a very high yield lecture, I'll pattern it based on dun sa how I also discuss it in the pharma boards, para at least mas directed yung ano natin, yung learning for this one. Okay, so let's start with your antibacterials. For your antibacterials, simulan muna natin sa mga tatlong ito. Actually, yung antibacterials natin, pwede mong isipin or i-classify sila into these three: the bacterial cell wall synthesis inhibitors, mga protein synthesis inhibitor, and yung nucleic acid synthesis inhibitors natin. Pag sinabing bacterial cell wall synthesis inhibitor natin, usually ito ay mga bactericidal agents. Kasi if you remember, if you recall dun sa synthesis ng bacterial cell wall, pag wala silang bacterial cell wall, pwede silang mamatay, kasi wala silang parang balat, parang ganun ko siya na-imagine. So lahat ng nandito sa bacterial cell wall synthesis inhibitor are bactericidal agent, while your protein synthesis inhibitors are static agent, bacteriostatic agent, most of them, except for some that I will be discussing later. And yung nucleic acid synthesis inhibitor natin, pag sabay silang binigay, they can also be cidal, or bactericidal. So ito yung mga tatlo na main divisions of your antibacterials. Let's start with your bacterial cell wall synthesis inhibitors. So you have the following, penicillin, cephalosporin, the monobactams, the carbapenems, and the others. So let's start first with your penicillins. Your penicillins are divided into the following, yung natural penicillins, anti-staphylococcal penicillins, and aminopenicillins, and anti-pseudomonal penicillins. For your natural penicillins, pinakakilala dyan ay si penicillin G. Your penicillin G and your penicillin V. Yung penicillin G, ginagamit siya intramuscularly, or it's given intramuscularly, while your pen V is for oral route. It's given as an oral route. V for vivig or V for bunganga. So yun yung dalawa nating types of your penicillin. Usually ang ating penicillin, ginagamit siya for the drug of choice for your syphilis. It's also given for patients with rheumatic heart diseases. Lagi ko to nakikita in the OPD. Minsan magi-inject ka intramuscularly nung penicillin G. And one of the side effects ng pen G talaga ay painful injection site, as in masakit daw talaga yung area na kung saan in-inject. Actually not here, mas dun sa buttocks, na pinagtusukan ng penicillin G. Okay? So those are your natural penicillins. Okay, next we go to your anti-staphylococcal penicillins. Your anti-staphylococcal penicillin, na-discover sila if we go back to the history, ang goal kasi before, kasi remember your penicillins are sensitive to your beta lactamases. Your beta lactamases ay isang enzyme na ginagawa ng ating mga bacteria para magkaroon sila ng resistance against penicillin. Ngayon yung mga sinaunang scientists natin, gusto nila na parang resistant sila doon sa beta lactamase. So dinagdagan ngayon nila ng, kunwari ito yung penicillin mo, dinagdagan nila ng isang malaking molecule, It's an isoxazolyl molecule. So yan siya, ganyan siya kalaki. Dinikit nila dun sa penicillin, What it does is, dahil masyado siyang malaki, nagkakaroon ng tinatawag na steric hindrance, hindi nakakapasok, hindi interact yung enzyme na beta lactamase doon sa beta lactam ring ng penicillin. No, remember your beta lactam ring is a 4-carbon molecule, no? So nandun siya sa core ng every penicillin natin. Hindi nakakapasok dito yung ating beta lactamase para masira siya, no? Dahil ang laki-laki ng molecule na dinagdag. However, okay, naging successful 'yon actually. Naging successful na they are beta lactamase resistant, no? Itong mga to beta lactamase resistant, no? Resistant sila, no? Kaya, no? However pala, kaya ang nangyari dahil naglagay ka ng napakalaking molecule, no? Nag-decrease ngayon yung kanilang coverage. Naging mas active lang sila sa staph, no? Kaya sila tinawag din na anti-staph pen, no? Ang palatandaan ko dito is your staph, okay? Your balak, okay? Balak means beta lactamase on Monday. Okay? Staph your balak on Monday. Okay? Staph for staph or staph pens, no? Balak for beta lactamase resistance, meaning hindi sila nasisira ng beta lactamase. And the mnemonic for that is MON. Okay? Methicillin, no? Oxacillin, and your naphthalene. Okay? So yung ating mga methicillin, oxacillin, and naphthalene, they are also involved, no? Na side effect. Meron silang side effect na tinatawag na interstitial nephritis. And your naphthalene, N for naphthalene, no? And can also cause neutropenia, no? Neutropenia. And for naphthalene, and for neutropenia. And next, you have your aminopenicillins. Your aminopenicillins, no, trinay ng alisin yung moiety, tapos nag-discover sila, nag-add sila ng amino group doon sa penicillin, no, compound, no. And ngayon yung aminopenicillins na to, meron na silang extended spectrum coverage, no. Mas covered na nila yung mga tinatawag na helps organism, no. Yung helps organism. Example nito yung mga Haemophilus, mga E. coli, mga Moraxella catarrhalis, no, kasama dyan dun sa mga different organism na may effect yung ampicillin and your amoxicillin. However, your ampicillin and amoxicillin are known to cause your pseudomembranous, okay? Pseudomembranous colitis, no? Pseudomembranous colitis is a certain ang tawag dito, condition wherein yung ating normal flora, naubos yung normal flora, mas na dumami yung tinatawag na Clostridium difficile. So nagkakaroon ng pseudomembranous colitis. Okay? And lastly, under your penicillins, we have your anti-pseudomonal penicillins, no? Ang palatandaan ko dito is PET in the city. No? PET in the city. PET for piperacillin. P for piperacillin. City, no? City is carbenicillin and ticarcillin. Okay? So yun yung ating mga anti-pseudomonal penicillins. So yung mga anti-pseudomonal penicillins natin, mas may gram-negative reaction sila, no, and mas may, syempre dun sa name nila, no, they have anti-pseudomonal property. However, no, tandaan natin, they are also inactivated by your beta lactamases. Tanong ulit, ano nga dun sa mga penicillin ang may may resistance sa beta lactamase? They are your anti-staphylococcal penicillins. Okay? So ayan. Inisa-isa na natin dito. So they are used for rheumatic heart disease, no? Methicillin, oxacillin, and naphthalene, sila ay yung ating mga drugs used for anti-staph. Okay, isoxazoline. This is just a review, no? Isoxazoline, yan yung dinagdag na molecule sa kanya. It can cause interstitial nephritis, neutropenia for your naphthalene. Okay? Quick review ulit for aminopenicillin, no? You added an amino group for them, and your ampicillin will have more coverage for your helps, di ba? Na mga organism, yung mga E. coli, Haemophilus influenzae, etc. Okay? And then your anti-pseudomonal, ang mnemonic dyan is PET in the city. Okay? Piperacillin, ticarcillin, and carbenicillin. Actually, yung piperacillin, no, you can mix them with your tazobactam, no, which is later on i-discuss natin yung mga different additional penicillin-related compounds. So what they do is they prevent the beta lactamase from degrading your main drug, no, your particularly kunwari piperacillin, no. So, okay. So those are your penicillins. Okay. Under bacterial cell wall, so tapos na tayo sa penicillins ha. Ano nga yung ulit mga drugs doon? Natural penicillins. We have your anti-staph penicillin, di ba? Nag-edit tayo ng molecule niya. And then iniba mo ulit, you have your aminopens and then your anti-pseudomonal penicillins. Now we go to your cephalosporins. Okay. For your cephalosporins, we have actually 5 generations, no? Pero I'll discuss the 4, no? Yung ating first generation, okay? For your first generation, so ang mnemonic ko dyan will be your cefdrozole, no? Okay? Lahat na nagsa-start sa cef, okay? Lahat nagsa-start sa cef plus dro and zol, okay? So anything that start with cef and yung merong sa gitna na dro and zol. Okay? Example nito ay cefadroxyl, no? Droxyl, okay? Kasi CEF siya pero meron siyang DRO kasi sa gitna, no? And then si zol is okay? Cefazolin. Okay? Cefazolin, no letter E. Okay? So yan yung mga first generation natin, no? CEPH kasama yung exception na dro and zol. Cefadroxyl and cefazolin. Okay? Your cefazolin, usually this is seen, no? Dun sa mga surgical prophylaxis natin, di ba? Usually, makikita mo yan sa mga orders ng Gen Surge, no? Pag operahan sila, naglo-load sila ng cefazolin. Okay? Next would be our second generation cephalosporin. So our second generation cephalosporin, sila yung mga nagsa-start sa CEF, no? Pero hindi nag-e-end sa own at IME. Ulit, na cef na hindi nag-e-end sa own at IME. Okay? Ito, idagdag nyo din si Laura Cefu. Okay? So imaginein mo, may kaaway ka na pangalan, Laura Cefu. Okay, sorry for the bad word, pero gano'n ko siya naaalala, no? Laura and Cefu. So lahat ng cef na nagsa-start, no? Pero dapat hindi sila nag-end sa own, hindi sila nag-end sa IME. Plus, si Laura, or Laura Carbef, and si Cefu, okay, cefuroxime. Okay, si cefuroxime. Okay? Those are your second generation. Okay, kung ang first generation ay mas gram-positive, okay, yung second generation natin, nagkakaroon na sila ng mas gram-negative coverage, no? Particularly, meron na tayong Haemophilus, no? Na coverage, Enterobacter, and Neisseria coverage, no, for your second generation. Now, for the third generation naman, okay, your third generation, ang mnemonic ko dito ay lahat ng mga nagsa-start sa cef, okay, at nag-e-end sa own, at nag-e-end sa IME, no? Yan, lahat ng mga nag-start sa own at IME, no? Ay, nag-e-end sa own at IME pero nagsa-start sa cef, okay? Plus si Moxie, Denier, okay, Denier, Ditoren, tsaka si Buten. Okay? Ito, very classic na mnemonic ko ever since nung pharma, undergrad years, no? Parang, imagine mo, Mara Clara, at ikaw si ano yung kalaban, no? Ikaw yung kontrabida. Okay? Meron kang kaaway, si Moxie, no? Siya si parang Mara, no? Siyempre, ano ka, kontrabida, no? So, kunwari, inom ka yan. Milk pa. Okay, so sabi mo, kunwari umiinom ka, ikaw yung kontrabida. Okay, so Moxie, sabi ganun. Can you please go Denier? Tapos buhos mo kunwari. Papunas naman Denier, oh. Okay, buhos mo yung iniinom mo. Tapos buhos mo dun sa other side. Sabi mo, oops, pati dito rin sa kabila. Yan. Tapos sarcastic mo sasabihin, buti na lang, andyan ka, no? So ayan, so ganun ko siya na-imagine, no? Si Moxie, punta Denier para punasan niya yung binuhos mong tubig, no? At saka dito rin, dun sa kabilang side, no? Tapos sasabihin mo sarcastically, no? Buti na lang, nandyan ka. Okay? So that's how I remember yung mga third generation. Hindi siya funny, pero na-imagine ko siyang ganun, no? So Moxie for moxilactam, no? Lactam. Denier is cefdenier, no? Ito, cefditoren, tsaka ceftibuten. Okay? Denier, dito rin, tsaka buten na lang, andyan ka. Okay? So those are your third generation na mga cephalosporin. Okay, pag third generation, di ba, as you go along, as you go higher dun sa generation, mas nagkakaroon ka ng lesser gram-positive effect and more gram-negative effect. Okay, so among your third generations, no? So erase ko lang to. Among your third generation, isa sa mga pinakilala dyan si Tria, no? Si Ceftriaxone or Ceftriaxone, no? Si Tria should fix her. Ay, sorry, nawala. Okay. Third generation, no? Si Tria, fix your gonorrhea. Okay? Tria, fix your gonorrhea, no? For Ceftriaxone, fix is Cefixime. Okay? Cefixime. Okay? So Ceftriaxone and Cefixime for gonorrhea. Okay? Next, lahat ng ating mga third generation ay may renal excretion. Ibig sabihin, they are renally excreted except for the following, no? Si Pera, okay? Si Pera ni Tria, okay? Si Tria, okay, ang palatandaan ko dito. Si Tria walang pera para makawiwi. Okay? Si Tria walang pera para makawiwi. Alam niyo yung pagka nasa mga malls tayo tapos magbabayad ka para makawiwi, no? Wala siyang pera pambayad doon, no? So si Tria walang pera para makawiwi kasi lahat ay renally excreted except kay Ceftriaxone and Cefoperazone. Okay? Next, all of our drugs are excreted, I can penetrate the blood-brain barrier, no? Except si, okay, Cefoperazone and si Cefixime. Okay? Mnemonic ko dyan, wala kang pera to fix your brain. Okay? Wala kang pera to fix your brain. Yan. So, kaya siguro akong, yan, sabaw-sabaw na. Hindi, joke. Wala kang pera to fix your brain. Okay? To fix your brain, no? Meaning, itong Cefoperazone and yung Cefixime, okay, are drugs on the under third generation na hindi kaya mag-cross the blood-brain barrier. Ang mas maganda at malakas na drug to cross the blood-brain barrier is Tria. Tria can enter the brain. Okay? Ceftriaxone can enter the blood-brain barrier. Okay? So, of all of these naman, si Ceptaz, okay? Kilala niyo si Taz, no? Yung si Tasmanian. Si Taz, magaling siyang mag-sudo. Okay? Magaling siyang sumudo. Parang gano'n. Sounds like bastos, pero si Taz ay magaling sumudo. Okay? So, ceftazidime, sudo. Okay? Pseudomonas. Alright? So, ayan. So, those are the most important third generation that we have to remember, no? Under your cephalosporins. Next, your fourth generation we will have your cefepime and si cefperone, no? Mas nagkakaroon sila ng wide coverage for gram-positive na ulit and gram-negative bacteria, no? Both na sila. So your fourth generation, okay? So those are your cephalosporin. So that's an overview of your cephalosporin, and I hope na hindi niyo na sila makalimutan. So the technique here is, if kunwari kapit patalim, hindi niyo maalala kung ano yung gamot na pwedeng ibigay, no? Kasi pwedeng yung ano natin, mga antibiotics, madami yung mga coverages, no? Ang way to answer drugs, yung mga questions about antibiotics ay you have to know their coverage talaga. So kailangan alam mo kung ano yung bacteria, is it a gram positive, is it a gram negative, no? Additional ano din to, link doon sa micro natin dapat. So dapat alam niyo sila yung positive or negative. Is it ang tawag dito, an anaerobe, no? Kasi it will help you determine kung ano yung certain drug. Kasi tandaan niyo, minsan yung mga question, walang specific na drug na for that condition, no? Minsan, what is the best that you can give? So you have to know. So again, pagka mga first generation, mas positive. As you go higher, mas nagkakaroon ka ng gram negative. Pero pagdating mo ng fourth generation, ikaw din ay may gram positive coverage. So yun yung importance na dapat alam mong i-classify yung first, second, third, and fourth generation, because that will help you answer the questions. Okay? Next, punta naman tayo sa the next three, no? We have your monobactams. Your monobactam include your aztreonam. Your aztreonam has no gram-positive activity and mas ginagamit lang siya for gram-negative coverage. Okay? Your Aztreonam also has pseudomonal coverage. Okay? It also has pseudomonal coverage. Next is your carbapenem. Okay? It's also a bacterial cell wall synthesis inhibitor. Kilala dyan si imipenem. May kita nyo penems. Okay? Yung ending nila. And yung meropenem. Okay? Among all of these, lahat sila ay may pseudomonal coverage. Okay? Lahat sila ay may pseudomonal coverage except for one. Which one is it? It's your ertapenem. Okay? Your ertapenem has no coverage against your pseudomonas, no? It has no coverage against your pseudomonas. But your carbapenems, they really have wide coverage for gram-positive and gram-negative bacteria and serious infections, no? Particularly for pneumonia and sepsis. Kaya lagi namin nakikita yan sa wards, no? Makita nyo, meropenem and amikacin, which is an aminoglycoside, no? Particularly sa antibiogram ng PGH, no? Yung merop and amic, lagi yan nagagamit. Okay? So, ERTAP, walang pseudomonal coverage. Okay? And others, syempre, yung ating vancomycin, no? Vancomycin, pinakakilala yan to cover for your gram-positive organism, no? Ang mechanism ni vancomycin is to bind to the diala, no? Diala terminus of your peptidoglycan, no? Na part siya ng cell wall, no? Ang palatandaan ko diyan, dala-dala mo yung vanco. Imagine mo malaking bangko, no? Dala-dala mo siya, okay? Dala-dala mo yung vanco. So vancomycin for usually mga gram-positive sepsis, no? Mga gram-positive sepsis or organisms such as your MRSA. What is the side effect of your vancomycin? No? It can cause your Redman syndrome. No? Nakakita na rin ako ng ganito sa ward, no? Nagkaroon siya ng ng Redman syndrome, so nagkaroon siya ng erythema along the whole body niya. So how do you correct that? You just decrease the infusion. Kasi ang nangyari, no, yung rate daw ng infusion nung na naibigay sa kanya nung nurse nung gabi ay nabilisan. So ang nangyari, nag-precipitate yung ating Redman syndrome. So what you do there is you can give your antihistamine and you can decrease the rate to prevent the yung pagkakaroon ng Redman syndrome. Okay? Next is your bacitracin. Your bacitracin, no, mas ginagamit lang to for ito, no, lakihan ko siya, bacitracin. Okay? Kaya ako nilakihan yung T, no, kasi it's used for gram-positive bacteria, no? Gram-positive, and it's also used topically, no? Topically. Okay? And it is also toxic, no? Kaya siya less used, no? It can cause nephrotoxicity as well. Okay? So yan. Yung cycloserine naman, it's another bacterial cell wall synthesis inhibitor na mas ginagamit lang sa tuberculosis as a second line agent. Okay? It's neurotoxic, no? Kaya siya less used. Okay? So similar to your vancomycin, it also, okay, blocks the incorporation of your diala. Okay? So yan. So those are your bacterial cell wall synthesis inhibitor. So again, balikan lang natin quickly yung mga different drugs. No? Ito yung mga carbapenems natin. Ertapenem, it doesn't have coverage for Pseudomonas. Meropenem has wide coverage for different types of sepsis. No? And your vancomycin, bacitracin, cycloserine, these are other types of your bacterial cell wall synthesis inhibitor. Important dyan, yung diala. No? Ginagamit si vanco for gram-positive sepsis or bacteremia din. No? Si bacitracin, ginagamit lang siya topically. Diba? Sineparate natin yung letter T. Si cycloserine, ginagamit siya for TB as a second-line agent. So these are your bacterial cell wall synthesis inhibitors. So that's all for your bacterial cell wall synthesis inhibitor. Okay? So hinga muna before we go to the next part, no? So you can pause the slides here at this point. Tapos balikan nyo yung mga dinaanan nating topics. Okay? And then when you're ready, we proceed to the next. Okay? Alright, kunwari natapos na natin yung break ninyo. We now proceed to the protein synthesis inhibitors. Now your protein synthesis inhibitors, remember, di ba, protein, saan nanggagaling ba ang protein synthesis natin? Sa ating ribosomes, di ba? Yung mga ribosomes natin na makikita sa mga cells, no? So, yung protein synthesis inhibitors can be divided into yung tinatawag nating by at 30, okay? And then cell at 50. So, by at 30, no? Cell at 50. Okay? Yung 80, no? 80, you have your aminoglycoside and your tetracycline, no? Because they inhibit your 30S na ribosomes, no? While your cell at 50, chloramphenicol, no? Macrolide for erythromycin and lincosamides, which includes your clindamycin, no, your clindamycin, they inhibit your 50S. Okay? They inhibit your 50S na ribosomal subunit. Okay? So let's start with your aminoglycosides. Yung ating aminoglycosides, no? So they are mainly used for gram-negative bacteria, no? So ang palatandaan ko dyan yung I, kunwari ito yung I ng aminoglycoside, no? Kunin mo siya, ihiga mo siyang gano'n. So sobrang medyo weird yung mnemonic, pero sobrang naalala ko siya until now. It's used for gram-negative bacteria, no? Aminoglycoside, kunin mo yung I, ihiga mo yung I. So gram-negative. So negative line, no? So, yan. So, included here, nag-end sila sa, yung ating mga aminoglycoside, nag-end sila with mycin or mycin, no? Mycin or mycin. Okay? Pero mapapansin nyo later yung erythromycin ay nag-end din naman sa mycin, no? And those are macrolide antibiotics, no? Ang difference nila with your aminoglycoside, meron silang thro sa pangalan. Thromycin, no? Azithromycin, erythromycin. Okay? So those are your macrolide antibiotics na i-discuss natin later. Okay? For your aminoglycosides, no? First, you have your NTG, your neomycin, dobramycin and your gentamicin. Ang pinaka-important actually, sige, in general na lang muna. Yung ating aminoglycosides talaga, no? They can cause kasi nephrotoxicity, no? Nephrotoxicity. No, pwede silang magkaroon ng acute kidney injury, no? Lagi 'yan kapag nasa wards kami, nagbibigay kami ng aminoglycoside, no? Particularly si amikacin, no? Si amikacin, binabantayan namin yung mga electrolytes niyan, no? Particularly yung ating potassium, no? Yung ating creatinine din as well, and yung magnesium. Kasi yung mga yan, no? Yung potassium and magnesium, they can be deranged, and yung creatinine bigla tataas yan, no? Kasi hindi na ma-excrete ng body dahil nasira yung kidney, no? So it can cause acute kidney injury, no? Tubulopathy from your aminoglycoside. So that's one side effect na kailangan nyo maalala. Okay? Other than nephrotoxicity, it can also cause your vestibulotoxic effect, no? Pwede silang mabingi, no? Pwedeng masira yung pandinig nila, no? Or pwede silang mahilo, no? Your SG, no? Your vestibulo are your most vestibulotoxic drugs, no? Na pagdating ang palatandaan ko diyan, SG. Pagdating mo sa Singapore ay bigla ka nahilo-hilo. Okay? So SG for Singapore vestibulotoxic. Now this one, NAC, these are your most ototoxic aminoglycosides. So NAK, NAC, no? Imaginein mo may kumakatok pa ulit-ulit, no? Pero hindi mo naririnig. Kasi bakit? Nabibingi ka na, no? Wala ka nang naririnig. Okay? These are the most ototoxic agent, no? Neomycin, amikacin, and your kanamycin. Okay? Your amikacin actually can also be used as a second drug agent for your tuberculosis. Okay? Your amikacin can also be used for tuberculosis. And remember, actually, dapat itong mga aminoglycoside mo, ginagamit mo sila together with other drugs. Kunwari, mga carbapenems mo, yung mga meropenem, no? Kaya makikita mo, mixture sila, meropenem and amikacin. Okay? Yun yung mga use nila. Okay? So, those are your aminoglycosides. So next, we have your tetracyclines. Your tetracyclines, no, these are drugs that act on your 30S ulit. Diba? Sabi natin yung at 30, diba? At 30. So your tetracyclines are mainly used for, okay, example niyan, sorry, are tetracycline, doxycycline, and your demeclocycline, no? Ginagamit sila madalas for your mycoplasma, no? Mycoplasma. Ang palatandaan ko kasi dyan, no, dati nagdo-draw ako ng parang egg. Yan. Draw ako ng 4 na egg. Yung mycoplasma kasi ang itsura niyan sa micro ay fried egg appearance. So nagdraw ako ng 4 na egg, no? 4 na egg, bakit? Tetracycline. Tetra means 4, no? So mycoplasma. So ganun ko siya nare-recall. So tetracycline for mycoplasma, and your mycoplasma is an example of an atypical pneumonia. So ginagamit yung mga tetracycline natin for patients na may atypical pneumonia, no? Pwedeng for mycoplasma pneumoniae. Okay? Your demeclocycline over here can also be used, ay nawala. Okay? Can also be used for SIADH. So demeclocycline, another use of this one, it can be used for the management of your SIADH. Now, your tetracycline, tandaan natin, para siyang chelating agent. Para siyang isang malaking molecule na pwede mag-chelate ng, para siyang sa 4 siyang molecule na ganyan, no? Na dun sa center ay merong space dyan na pwedeng dikitan ng calcium. Okay? So, kaya siya nagiging chelating agent, no? Tetracycline, so may calcium doon sa gitna. And ang important dito, ba't ko pinakita yung it can chelate your bivalent ions, no? Kasi remember that it can also cause enamel dysplasia or discoloration dun sa tooth. Kasi parang sinesequester niya, sinisira niya, kinukuha niya yung calcium from the bones, no? Kaya nas nagiging brittle, no? And yan yung one of the teratogenic effect of your tetracycline. So you don't give it to pregnant women, no? You don't give it to your pregnant women. So next, we have your chloramphenicol. Okay? Your chloramphenicol was previously used, no, for yung ating mga meningitis caused by your S. pneumoniae, no, your Haemophilus influenzae, and your Neisseria meningitidis, no. But important sa chloramphenicol ay meron siyang side effect na aplastic anemia, no, aplastic anemia, and it can also cause your gray baby syndrome, no. Gray baby syndrome. Ito yung pinaka-important na kailangan yung matandaan sa kanya, no? Kasi ang nangyayari dito, no, yung chloramphenicol, it's metabolized by the glucuronidation step. Pero yung mga babies, wala pa silang functional na glucuronidation step. Kaya ang nangyayari, nag-build up yung chloramphenicol, nagko-cause siya ng parang ashen gray skin, no? Parang nagiging gray yung color niya. Okay. So next we have your macrolides. As said a while ago, macrolides end in thromycin, no? Thromycin, azithromycin, erythromycin, no? And itong mga to ginagamit sila madalas, no? Maririnig niyo yung azithromycin, no? For your community acquired pneumonia or CAP. Okay? So azithromycin. One of the side effect of your macrolide ay mag-complain yung mga pasyente niyo na, Dok, masakit yung tiyan ko, makirot yung tiyan ko. Okay, so because it causes GI upset. And one of the side effect of your macrolide ay QT prolongation. Okay, mga cute ang mga macrolides. Okay, cute macrolides kasi may QT prolongation sila. Okay? So those are your macrolide antibiotics. Next, we have your lincosamides. So under your lincosamides, we also have your clindamycin and lincomycin. Ginagamit ito madalas, okay, saan? Saan yung naririnig? Sa mga skin infections, no? Skin infection, lalo na yung mga malala na skin infection tulad ng necrotizing fasciitis, mga ganyan, yung mga anaerobic infection sa balat, no, ginagamit ang clindamycin for them, no. Your clindamycin, similar to your aminopenicillins earlier, it can also cause your pseudomembranous colitis, no, pseudomembranous colitis. Okay, that's for your lincosamides or clindamycin. Okay, so dati ang laging siguro not really clinically applicable, no, pero for the board's sake, no, ang clindamycin ginagamit siya for anaerobes, no. Remember, ito ang isa sa kanyang use, no, anaerobes, no, above the diaphragm, no, above the diaphragm. Pero pag below the diaphragm, okay, you give your metronidazole. Okay, pero clinically depende sa kung ano yung pwedeng maibigay. Pero for the board's sake, no, above the diaphragm na infections na anaerobic, usually clindamycin, metronidazole pag below the diaphragm. Okay? So those are your lincosamides. So just a quick review ulit, no? Ito yung mga aminoglycosides natin. Para saan nga ulit siya? Sa mga gram-negative infection. Sino nga yung may pinaka-vestibulotoxic? CSG, no? Streptomycin and gentamicin. Di ba na hilo-hilo ka pagdating mo ng Singapore. Knock-knock, no? For you to remember ototoxicity. Remember that every one of them will cause, no? Can cause your acute kidney injury. And ano yung mga babantayan nating electrolytes? Potassium and magnesium, and as well as your ito hindi electrolyte, creatinine trends. No, kailangan makita mo na bumababa na siya to know that the AKI is resolving. Okay? So those are your aminoglycoside. Tetracycline, ang sabi natin dito for atypical pneumonia kasi yung mycoplasma, ano nga itsura niya in dun sa microbio natin na mga lectures, it looks like a fried egg appearance. Tapos nag-draw ka ng apat, no? For you to recall that it's tetra, okay? It's tetracycline for your atypical pneumonias, no? And your doxycycline pala, sorry, I wasn't able to mention. It can be used for yung mga leptospirosis na prophylaxis and treatment as well. Okay, the meclocycline para sa SI-ADH. So yung chloramphenicol, nabanggit natin yan kanina, and ang most important thing to remember about that is it can cause aplastic anemia and gray baby syndrome. Your thromycins or your macrolides, okay, they prolong, ano nga ulit? Yung QT, di ba? Cute macrolides, di ba? Cute macrolides. And they can also be used for patients with CAP, no? Yung azithromycin na for 3 days. And lastly, yung clindamycin, they are used for anaerobic infection, and also mga skin infections, no? Skin infection, particularly mga necrotizing fasciitis. Okay? So those are your lincosamides. So under your protein synthesis inhibitor. And lastly, to just give an overview, no? Ito nga ay nag-inhibit ng 50S and ito ay nag-inhibit ng 30S. All right? And your aminoglycoside among every one of your protein synthesis inhibitor, lahat sila ay bacteriostatic except for your aminoglycoside, which is bactericidal. All right? So those are your protein synthesis inhibitor. Ngayon, pag tinanong na kayo, no, kung ano yung mga uses nila, no, or if it's bacteriostatic or bactericidal, you can already parang anong tawag dito? Pwede mo siyang gamitin or think backwards, no? Kunwari binigyan ka tetracycline. Ang tetracycline ay isang protein synthesis inhibitor, di ba? It inhibits 30S, okay? And sabi natin lahat ng protein synthesis inhibitor ay bacteriostatic maliban kay cidal. So pwedeng ganun mo siya isipin, no? Kung ano yung drug na binanggit, okay? Alamin natin kung i-recall nyo kung anong mnemonic, kung saan mo siya narinig, and then dun mo malalaman kung ano yung mechanism of action niya. Basta lahat, guys, nasa protein synthesis inhibitor natin, sila yung buy at 30, sell at 50. Okay? Buy at 30, sell 50. Okay? Kanina, yung mga penicillin natin, mga bacterial cell wall synthesis inhibitors sila. Okay? And lastly, we have your nucleic acid synthesis inhibitors. So yung mga nucleic acid synthesis inhibitor natin are divided to your antimetabolites and your fluoroquinolones. Okay, your antimetabolites, no? These are drugs that prevent yung production ng ating folic acid, no? So ang nangyayari dito, yung mga sulfonamides natin, as you can see in this picture, it inhibits your dihydropteroate synthase, no? Yung S for S, okay, synthase for sulfonamide, okay? The next one is R for trimethoprim. Hindi siya R, pero magkasunod siya, QRST, okay? So R and T, they are near each other. Yung isa S and S, okay? Synthase sulfonamides, reductase, trimethoprim. So ito yung tinatawag na trimethoprim sulfamethoxazole combination, yung TMP, no? SMX. Okay? Alone, pag ginamit mo yung mga drug na yan, they are only bacteriostatic. Pero when you give them together because you block the sequential step in the production of your purines, no, ang nangyayari ay nagiging bactericidal din siya. Okay? So, that's how they inhibit yung proliferation ng bacteria. Kasi DNA na yung inapektuhan mo eh. Tinanggalan mo sila ng purine. Mamamatay ngayon yung bacteria kasi wala siyang way to replicate, no? So that's how your nucleic acid synthesis inhibitor works. Kumpara natin yung kanina, protein synthesis inhibitor, pwede lang siyang mag-inhibit ng protein na kinakailangan ng bacteria para mabuhay, no? Kaya siya parang usually parang static lang sila. Pag nucleic acid, pinatay mo yung or ininhibit mo yung mismong genetic code niya. Kaya hindi siya ganon ka daling mag-replicate. Okay? Your fluoroquinol ayan. So, example niyan, your cotri and your silver sulfadiazine. Okay? So, it inhibits your sequential step in the formation of your purines. So, toxicities from your sulfonamides include hypersensitivity, GI distress, pwede rin siyang maging hematotoxic, no? Pwedeng nephrotoxic din sila. Okay? And next, you have your fluoroquinolones. Your fluoroquinolones, you have 4 generations of your fluoroquinolones. Okay? So first generation, okay, we have yung ating nalidixic acid. Siya yung parent drug, no? Siya yung pinakakilala na parent drug under your fluoroquinolones. So sa kanya nang galing lahat ng mga synthesis ng other drugs. Pero yung ating nalidixic acid hindi na siya masyadong ginagamit, no? For the management of our bacterial infections. Okay? For your second generation, ang palatandaan dyan ay si con. Okay? Contour. Okay? Contour. Okay? Contour. So, included dyan si ciprofloxacin, no? Si ofloxacin, and your norfloxacin, no? The use of your ciproflox, norflox, and ofloxacin, minsan ginagamit sila for urinary tract infections, no? Mga gram-negative rods such as yung mga salmonella, shigella, mga ganyan, campylobacter, no? They can also be used for your atypical pneumonia, no? Tandaan natin na dito sa second generation, pinaka-active na gram-negative talaga doon sa kanila ay si ciprofloxacin, no? Except that wala lang siyang activity for your Pseudomonas, okay? No activity for your Pseudomonas, si ciprofloxacin, all right? So those are your second generation, si Contour, okay? Ciproflox for has the most gram-negative coverage from the list, and it's used for these drugs can be used for urinary tract infections for the organisms mentioned earlier. Okay, next punta tayo sa ating mga third generation. So yung third generation example na pinaka-common would be your levofloxacin. You also have your moxifloxacin and your gemifloxacin. Okay? Among the third generation, in-list down ko din dun sa yung drug list ninyo, dun sa handouts ninyo, yung mga most common na tinatanong, no? Yung Grepa na hindi na siya ginagamit kasi for its severe cardiotoxicity. Yung Gati, no? Gatifloxacin, it's also withdrawn due to the propensity to cause diabetes mellitus. Gati sounds like gatas, no? Gatas, parang it's also, di ba, lactose, di ba? It's a sugar, no? So parang ganun ko siya imagine. It can cause diabetes mellitus. So parang ganun ko siya na-connect for each other, to each other. Okay? Your afloxacin can also be used for chlamydia trachomatis, no? Under your third generation. Levofloxacin, pinakakilala siya for the treatment of your atypical pneumonias, no? Example niyan yung mga chlamydia, mycoplasma, no? Yung mycoplasma pneumonia. Ano na nga yung atypical kanina na ginagamit na gamot for mycoplasma? Your tetracycline. No, your levofloxacin also has an atypical coverage. Okay, ano pa yung mga atypical pneumonia natin? Yung ating from Legionella, no? Tandaan niyo yan, ha? Legionella, mycoplasma, and your chlamydia can cause your atypical pneumonias. Okay, so community-acquired pneumonia that can be classified under your atypicals. Okay, and lastly, you have your fourth generation. So example niyan yung trovafloxacin. So yung trovafloxacin will now have an enhanced coverage against your anaerobes, no? Mga anaerobes. Ito rin, yung fourth generation ay may gram-positive and gram-negative reaction. Okay? Gram-negative and gram-positive reaction. Again, for your fluoroquinolones, opposite to your, ano, to your, ang tawag dito? cephalosporins, no? Yung mga first generation natin, mas meron silang gram-negative coverage, no? And as you go along, nagde-decrease yun, mas nagkakaroon sila ng gram-positive coverage and lesser gram-negative coverages. Okay? So just a quick review of your different fluoroquinolones, no? Ciprofloxacin, ofloxacin, and norfloxacin are under your generation 2, no? Contour, di ba? Contour, no? Contour. Ginagamit siya for UTI, yan. Okay? And other bacteria na nabanggit earlier, no? Third generation, you have your levofloxacin, no? Siya yung pinakakilala. It's mostly used for your atypicals, yung mga chlamydia, yung mga Legionella, and as well as your Mycoplasma, no? So those are your respiratory fluoroquinolones as well. And the fourth generation, so ito pala yung mga respiratory fluoroquinolones. Provafloxacin can have a wider coverage na for your gram-positives and your gram-negatives. Okay? So that's all for our for our antibacterials. Now we go to the antimycobacterials. Okay, you just take a short break first and then we'll resume after a while. Okay, so para hindi kayo ma-overwhelm, try nyo muna i-digest yung mga diniscuss natin earlier. Alright? Sige, we now go to antimycobacterials after. Okay, so let's now move on to the next set of topics under your antibacterial agents, no? We have your antimycobacterials. Pero sige, before tayo mag-start sa antimycobacterials, daan na lang natin yung brief summary ng antibacterials natin. Ano yung sabi nating main divisions nila? You have your cell wall synthesis inhibitors, you have your protein synthesis inhibitors, and yung nucleic acid synthesis inhibitors. Under your under your cell wall synthesis inhibitor, meron tayong penicillins, di ba? The penicillins can be divided into your natural penicillins, your aminopenicillins, your anti-staph penicillin, and your anti-pseudomonals. Tapos, under din sa bacterial cell wall synthesis inhibitors natin, you have your cephalosporins, and then your mga carbapenems natin, and your other cell wall synthesis inhibitors such as vancomycin, mga ganyan, bacitracin, okay? Next, you have your protein synthesis inhibitor, okay? Sabi natin, cell wall pala ay bactericidal. Okay? Next, protein synthesis inhibitor. Protein synthesis inhibitor, sila ay mga, yung lahat ng mga under dito you will be guided by the mnemonic na by at 30 and cell at 50. Okay? Cell 50 by at 30. Alright? So, di ba A for your aminoglycosides, T for your tetracycline, C for your chloramphenicol, E for your erythromycin or all of your macrolides, and then your L for your lincosamides, your clindamycin. Okay? And lastly, your nucleic acid synthesis inhibitor. No? Itong mga to, divided sila into two. You have your ang tawag dito, fluoroquinolones and yung mga antimetabolites natin. Yung antimetabolites include yung sulfamethoxazole, yung mga sulfonamides natin, yung mga sulfur-containing drugs, and your trimethoprim. And your fluoroquinolones, di ba sabi natin, you have 4 generations, no, of your fluoroquinolones, no? Una, sinalidixic acid, tapos yung mga second generations na si CON, yung third generation, yung mga respiratory quinolones natin, si levofloxacin, for atypical pneumonia. And lastly, yung mga for gram-positive and gram-negative coverage, yung fourth generation natin. Okay? So those are your whole antibacterials, no? In summary, no? I hope mas mapapadali pa nito yung inyong pag-aaral, no? Once you read more of the handouts. But I already included doon sa mga diniscuss natin yung mga important points na kailangan nyo ma-remember. Okay, next, for tuberculosis. Your Mycobacteria tuberculosis is mainly treated by these 4 drugs, no? Isoniazid, rifampicin, pyrazinamide, and your ethambutol. Ang importance sa tuberculosis, kailangan alam natin kung ano yung mga mechanism of action, ano yung mga side effects nila. So for your isoniazid, ang ginagawa nito, it inhibits your mycolic acid, no? Mycolic acid, no? And it can also cause hepatitis, hepatitis, and neurotoxicity. Kaya for some patients na, for example, na nakikita namin, no, minsan tinitingnan natin yung ALT, AST levels nila prior to giving your anti-TB meds, no? Kasi minsan makikita mo yan, mag-shoot up yung AST and ALT, no? Nagkakaroon sila ng hepatitis, no? So yan, drug-induced. Okay. So to prevent then yung neurotoxicity for isoniazid, ano yung vitamin na kailangan yung ibigay sa kanila? You have to give your vitamin B6, also known as your pyrazinamide, no? Pyrazinamide. So next, punta tayo sa rifampicin. O yung mga rifampicin is another first-line agent for your tuberculosis. Madalas magkasama sila ni isoniazid, di ba? Your rifampicin inhibits your RNA polymerase. R, no? For another R, okay? RNA polymerase. Okay? So RNA polymerase, okay, is the substance is an enzyme, no? That is being inhibited by your rifampicin, no? And your rifampicin is associated with another R, your red orange colored urine, no? Makita niyo yan, no? Yung dun sa kunwari urine nila, as in makita niyo red orange. And for some patients na nakikita ko na naka-rifampicin talaga, makita mo yung ang tawag dito, polycat nila, yung urine bag nila, as in red orange talaga. And for some na bantay or watcher, for example, no, magugulat sila kapag kunwari nag-start ka ng ganyan. Dok, dinudugo po yung pasyente ng yung hihi niya, no? So sabihin mo, it's a normal side effect of your rifampicin, lalo na pagkaka-start lang. Okay? Another R for your rifampicin is rapid development of resistance, no? Rapid development of your resistance, no? Kaya important na malaman mo kung yung tuberculosis ba na yun ay rifampicin resistant, no? Kasi mag-iiba yung management natin sa kanila. All right? And so those are the main points for your isoniazid and your rifampicin. Okay? So next, punta tayo sa pyrazinamide. Si pyrazinamide, actually yung mechanism of action nito is unknown pa at this point, but the main parang selling point of your pyrazinamide, it's because it's used as the sterilizing agent, no? During the first 2 months of your therapy. Now, similar to your isoniazid, no? Isoniazid, it also has hepatitis, no? It can also cause it also has hepatitis. It can also cause hepatitis. In fact, your pyrazinamide has the highest propensity to cause your hepatitis. No, it's the most hepatotoxic among the four drugs for tuberculosis. Okay, so that's your pyrazinamide. Okay. So lastly, for your primary agents, we have your ethambutol. Your ethambutol, okay, ang palatandaan ko dyan, si Etham ay mukhang Arab. Okay, so Etham the Arab. Okay, Etham the Arab. All right. So ayan. So ethambutol inhibits your arabinosyl transferases kasi, no? And one of the side effects of your ethambutol ay visual disturbances, particularly yung tinatawag nating red-green color blindness, no? Red-green color blindness. Okay. So that's for your ethambutol, right? So yan. So another thing for ethambutol, it can also cause your optic neuritis, no? It mostly ang side effect ng ethambutol ay mas dun sa opta related, no? So sa mata. Okay, ang palatandaan ko diyan, no? Ethambutol. O for parang mukha siyang mata. All. Okay? Eyes. Or pwede rin E for eyes. Okay? Yan. Pero yan, ethambutol. So E for eyes. Alright? So yan, those are the primary drugs for your tuberculosis. And of course, meron tayong mga second-line agents, lalo na pagka madami ng resistance, no? You can also give your aminoglycosides, yung streptomycin, tas kanina, di ba, pwede rin yung amikacin, di ba, for them, no? Those are your second-line agents. But for now, we focus dun sa primary agents for your tuberculosis. Okay, next we have your anti-leprosy drugs, no? Dalawa lang yung pinaka-important dyan, no? And the most active drug among them two is yung tinatawag nating dapsone. So it's the most active Okay, it's the most active against your M-leprae, no? And it's usually in combination with your rifampin or your rifampicin and your clofazimine. Okay, so clofazimine. And ginagamit sila for leprosy na may sulfone resistant, or if resistant ka to dapsone, no, you give your clofazimine. Okay, ang one of the side effect na clofazimine is nagkakaroon ka ng skin discoloration. Right? Color. Ang palat na ko dyan. Color. Yan. Chlorphazimine. Okay? For skin discoloration. Okay? Chlorphazimine. It can cause skin discoloration. Okay? Those are your drugs for yung tuberculosis. Alright? So let's now move on to our antifungal agents. Okay? So, for our antifungal agents, no? Yan, isa-isahin natin sila. They can be divided into your superficial mycosis, no? Ibig sabihin, nandun lang sa parang skin level, no? Superficial mycosis, you have your griseofulvin, terbinafine, nystatin, and clotrimazole. Ay, oh my God. Nauna siya. Okay? Griseofulvin, terbinafine, nystatin, and your clotrimazole, no? So isa-isahin lang natin sila saglit. So your griseofulvin, it's a microtubule inhibitor, no? It's a microtubule inhibitor. Yan, it's a microtubule inhibitor, and mas ginagamit siya, no, sa mga dermatophytosis, yung mga fungal infections sa ating skin. So mas derma drug talaga siya, no? And it's one of an important part of its pharmacokinetic is that it's a potent CYP inducer, no? Ay. Yan. It's a potent CYP or CYP450 enzyme inducer. And important thing to remember with griseofulvin, no? Tandaan niyo yung grease. Grease sounds like yung fat, di ba? Sebo, okay? Kasi kailangan mo siyang i-take together with a fatty meal, okay? Para mas ma-increase yung absorption niya. All right? So that's for your griseofulvin. Next, we have your terbinafine. Your terbinafine is an example of an allylamine, okay? Ang ginagawa ng mga allylamine is it interferes with your ergosterol, no? Ergosterol synthesis. And your ergosterol synthesis is important kasi in the formation of your anong tawag dito? Your fungal cell wall, no? Ergosterol synthesis. And how does it do that? It inhibits your squalene epoxidase, no? Squalene oxidase, I mean. Okay? Squalene oxidase. So your squalene oxidase, when it's being inhibited, no, yung formation ng ergosterol mo for the membrane ng ating fungi, no, ay nawawala or nai-inhibit. All right? So that's how your terbinafine works. However, it can cause your GI upset, yung mga rashes, and as well as headaches. Okay? So other than your tawag dito, the griseofulvin and your terbinafine, which are commonly used, no, as an oral agent, no, yung ating nystatin and your clotrimazole. So these are drugs that can be used for skin infections, no, na topical. Okay? Mas ginagamit sila topically. Okay? So your nystatin, no, nakikita ko to lagi for patients na may candida, for example, sa singit, ganyan, pwede kang magbigay ng nystatin na cream, or you can also give yung nystatin for gargling, no, yung particularly for mga patients na may oral thrush, no, your nystatin parang solutions, okay, for oral and esophageal candidiasis. So that's the use of your nystatin na antibiotic, no. Next would be your azoles, no? Particularly your clotrimazole. Your clotrimazole, ang ginagawa nito, it blocks your P450, no? Fungal P450 enzymes, no? Fungal P450 enzymes, thereby blocking ergosterol as well. Similar siya kay terbinafine, okay? No? Similar siya kay terbinafine, but okay, ito yung P450 enzymes yung in-inhibit niya. Dito, si squalene epoxidase. Okay? So remember that your azoles are limited to topical use because of their systemic toxicities. Okay? So ginagamit siya sa mga mucocutaneous candidiasis, no? Pwede rin siya dun sa mga, di ba, kung naalala yung clotrimazole, ginagamit siya for dun sa yung, ano yun, advertisement ni Rufa May, yung goodbye sa fungi, sa alipunga, yung mga ganyan, mga topical, no? Creams para sa mga fungal agents, fungal infections natin. So, dun yung ating mga superficial mycosis. Okay. Next, we have your systemic mycosis. No? Ito yung mga nandun na sa ating bloodstream, for example. So, for systemic mycosis, no, main drug under that we give for systemic mycosis is si amphotericin B. No? Lagi ko nakikita si amphotericin B sa wards, particularly for yung mga may fungemia. Fungemia means may fungal infection ka na sa bloodstream, no? It's your queen of all fungal, antifungal drugs, no? Si Ampho B, si Queen B, no? Queen B. No? So yan, mga systemic infections, kunwari cryptococcus, histoplasma, yung mga candida na systemic or nasa ano na, bloodstream na, candidemia. Okay? The amphotericin B is known to be very nephrotoxic as well. So you have to check kung nagkakaroon ka ng acute kidney injury. Okay? You check for your creatinine levels when you give your amphotericin B as well. Okay? So yan, again, siya yung Queen B. It's the drug of choice for most of your systemic mycosis. Next, we have your flucytosine. No? Your flucytosine, no, it's a pyrimidine antimetabolite. No? Pyrimidine antimetabolite. If you remember, cytosine is an example of a pyrimidine. Diba? Yung pyrimidine natin, yung cut, diba? Yung cytosine, uracil and thymine, di ba, sa DNA. So ang ginagawa nito, nagkukunwari siya as a cytosine, no? Para magmukha siyang pyrimidine, okay? Para pumasok siya sa DNA ng ating fungi, thereby yung therefore yung synthesis ng DNA ng ating fungal organism ay hindi magko-continue. Magka-cut siya, no? Doon sa replication niya. Kasi naipasok yung ating pyrimidine analog, no? Which is your flucytosine. So hence inhibiting yung parang pag-proliferate ng organism natin. All right? So that's your flucytosine. Your flucytosine can be given together with your amphotericin B and as well as yung mga azoles natin para magkaroon ng synergistic reactions. Okay? You can also give this for yung mga systemic candidiasis natin. All right? So next, we have your azoles. Your azoles such as your ketoconazole, yung mga fluconazole natin. Ayan, yung pinaka-important dyan, yung fluconazole, no? Yung fluconazole, no? Nakikita nyo to for patients na may cryptococcal meningitis, no? Cryptococcal meningitis, no? It's a type of fungal infection na makikita sa patients na may AIDS, no? It's an AIDS-defining organism. Ibig sabihin, sobrang baba na nung ating systemic yung immunity natin, no? Kaya nagkakaroon ka ng cryptococcal infection. So it's it is also your fluconazole is an alternative for your amphotericin B. Kung kunwari hindi mo maibigay si amphotericin B for some reasons, kunwari you can give your fluconazole as an alternative. All right? So, yan. So, there are several other agents pa, no? Under your azoles. Meron din tayong itraconazole and your ketoconazole. So, mostly yung ketoconazole, they can be given for your mucocutaneous candidiasis as well. Okay? So, ayan. Pero ito, important sa azoles natin, si fluconazole. Okay? An alternative for your cryptococcal meningitis. So, nabanggit na to kanina, ketoconazole for mucocutaneous candidiasis, no? Fluconazole for your systemic or, for example, alternative for amphotericin B can be given for your cryptococcal meningitis, no? And your itraconazole, no? Pwede yan sa mga blastomycosis, yung mga rare fungal infection na sporotrichosis, mga ganyan. Alright? So, those are your azoles. Okay, so we're done with your antifungal agents. We now proceed to our antiviral agents. So you can stop here first para tignan nyo, basahin nyo, or mag-add up kayo dun sa mga nabanggit natin na mga topics dun sa antifungal natin. Alright? So but I also gave na yung mga high yield and yung mga pearls natin for the antifungal agents. Okay, so next punta tayo sa antivirals. Punta muna tayo sa drugs for herpes infections, no? Yung mga herpes viruses natin. Example dito is your acyclovir and your valacyclovir. No, yung acyclovir ginagamit yan sa mga HSV infections, no? HSV1 and HSV2, herpes simplex virus 1 or herpes simplex virus 2, no? Ito yung mga herpes na oral herpes, yung mga reproductive or dun sa anong tawag dun? Genital herpes, no? Ito you can give them as treatment. It can also be given, no, acyclovir for your VZV, di ba? Your VZV or your pox, chicken pox, no? Acyclovir can be given for your varicella zoster virus. Okay? So ginagamit siya for HSV and VZV. So yun yung ating acyclovir. One of the side effect of your acyclovir is nephrotoxicity, no? It can cause precipitation of your crystals, no? Lalo na pag hindi uminom ng madami yung pasyente natin na nag-acyclovir, no? Naalala ko before when I was diagnosed with chickenpox, bigyan ako sa PGH ng acyclovir and I was given parang tablets for 4 tablets each per day, no? And naalala ko sobrang lala na side effect niya. And dahil takot na takot akong mag-crystalluria, no? Naalala ko na sobrang dami kong iniinom na tubig that time. Up to the point na sobrang hilong-hilo na ako and sukang-suka, no? Ngayon, para lang maalala ninyo na yung side effect ng acyclovir can cause, no, crystalluria. Pero hindi naman ako nagka-crystalluria. Okay. So that is for your drugs for acyclovir. Drugs for your VZV or your herpes simplex viruses, no? Your ganciclovir, no? Ang main primarily use niya, mas ginagamit siya for your CMV infection or cytomegalovirus virus infection. But it can also be used for yung mga HSV and yung VZV infections natin, no? Tandaan natin na yung valganciclovir is a prodrug for your ganciclovir, no? Pag na-metabolize siya ng ating liver, it also produces gancite. Alright? So, si Dofovir naman, no, mas ginagamit siya for mga CMV retinitis. Right? CMV retinitis. So, those are for the treatment of your cytomegaloviruses. Alright? So, next, punta tayo sa ating drugs for HIV. No? So, sorry. Wala lang. Nadoble. Okay, next, for your drugs for HIV, no, we have the following. We can classify them into your NRTIs or your NNRTIs, your protease inhibitors and your entry inhibitors, and your integrase inhibitors. Okay? For your NRTIs, okay, yung NRTIs, ang palatandaan ko dyan ay DAZLEST. Okay? DAZLEST. Okay, your DAZLEST, kasama dyan yung Z for zidovudine, A for abacavir, didanosine, M-tricitabine, mga ganyan, lamivudine. Okay? Among the NRTIs, no, ang isa sa mga ginagamit for HIV ay yung lamivudine, no? Lamivudine and yung tenofovir. Actually, mas si tenofovir. So makikita niyo yan dun sa LTE na combination, no? So, lamivudine, tenofovir, and your efavirenz. Kasi kailangan mo daw ng dalawang NRTIs, no? So, kailangan kasi combination drug for HIV kapag, and one NNRTI. Okay? Kaya yan yung combination niya. Alright? So, lamivudine and your tenofovir. Your lamivudine can also be used for your hepatitis B infections, no? Your hepatitis B infection. Okay, ang difference ng NRTI with that of your NNRTI, okay? It inhibits your reverse transcriptase, no? It inhibits your reverse transcriptase, okay? Transcriptase after phosphorylation, okay? Ang keyword dyan ay after phosphorylation. Compare mo yan doon sa NNRTIs, no? Yung NNRTIs, you have no, okay? No phosphorylation needed para ma-inhibit mo yung reverse transcriptase. Okay? Kung makikita niyo siya, 'di ba? Ang name kasi ang NRTI kasi is nucleoside, 'di ba? Reverse transcriptase inhibitor. Ibig sabihin, 'di ba kasi yung HIV natin meron siyang capacity to induce yung reverse transcriptase for it to replicate, no? And ang gusto natin gawin, ma-inhibit mo 'yon. Okay? Using your reverse transcriptase na mga drugs. You have your NNRTI and your NRTIs. Okay? Ang difference nila, this is after phosphorylation, and NRTIs, walang phosphorylation na kinakailangan. Alright? Yun yung difference ng dalawa. Ang difference din dun sa naming ng dalawang drugs na ito ay yung ating NNRTIs, nasa gitna yung vir. Okay? So, nasa gitna yung vir. I-compare mo sila dun sa iba na drug, yung NRTIs natin, yung vir nila ay nasa dulo, no? Aside from the fact na it's parang you are helped by the mnemonic na DASLess, no? Yung NNRTIs natin may vir sa gitna. Okay? Delavir din, no? Efavirenz, no? Ertavirapin, okay? Tapos basta lahat ng vir nasa gitna, it's an NNRTI. Okay? So those are your NNRTI. So you need 2 NRTIs, no, and 1 NNRTI. So yan yung old na combination ng ating drugs for HIV. Pero ngayon mas ginagamit na yung dolutegravir, which is an integrase inhibitor, no, integrase inhibitor in lieu of your efavirenz. So remember that your efavirenz kasi it can cause, no, yung ating mga vivid dreams, ganyan, lucid parang memories, mga ganyan, and medyo it becomes debilitating for some patients kasi medyo yung focus, yung attention ay nawawala pagka nagte-take ng efavirenz. So that's one side effect that we didn't want to have our patients with, no? Kaya tinanggal na si efavirenz dito, no? And pinalitan na ng integrase inhibitors, no? Using your dolutegravir, no? Dolutegravir. All right? So, yan, daanan natin siya later, no? So, we'll now go to the protease inhibitors naman. So, your protease inhibitors, by the name itself, no? Protease, it inhibits yung viral protein processing. So, ini-inhibit niya yung processing ng proteins ng HIV, no? So, ngayon, ito, it has an ending na navir. Okay? Navir. Okay? Ending. Indinavir, amprenavir, sakinavir, telapavir, mga ganyan. Okay? So, mga ending with navirs, these are protease inhibitors. Okay? So, aside from that, no, ang important lang tandaan sa kanila is they inhibit yung protein processing ng ating ng ating HIV. Okay? And next, we have your entry inhibitors. Your entry inhibitors include your enfuvirtide, and your maraviroc. Okay? Your enfuvirtide, it binds to your GP41 enzyme, no? Which is part of the viral envelope of your HIV. So preventing yung fusion ngayon nung drug papasok dun sa cell, no? Pag na-inhibit mo si GP41, si virus hindi siya makakapasok dun sa cell kasi inhibited si GP41. Ngayon, si maraviroc naman, kung si si enfuvirtide ay GP41, si maraviroc, ang ini-inhibit nito is CCR5, no? It's another receptor dun sa membrane that inhibits the attachment. Okay? Si Mara ay ayaw ma-attach. Okay? Si Mara ay ayaw ma-attach dun sa cell. Alright? Si maraviroc. Alright? So no attachment. And lastly, we have your integrase inhibitor, no? Remember that for your HIV to multiply, no? Kailangan niyang gumawa ng madaming DNA of its viral copies of itself, no? Kailangan niyang gumamit ng madaming mechanism na mapadami yung DNA niya. Ngayon, to do that, ini-integrate niya yung DNA niya into the DNA ng cell, no? So ngayon, pag nag-replicate yung DNA, nag-replicate din yung viral DNA natin. So you want to prevent the integration of your DNA to the DNA of your host, no? Kaya integrase inhibitor sila. Example nito ay si dolutegravir and your raltegravir, no? Yung ending nito, meron silang gravir sa pangalan. Grav, okay? Grav, GR, sounds like yung grace, GR. Then integrase, no? Gravir, all right? So those are your integrase inhibitors. Okay. So ayan, just a quick review of everything, no? And RTIs, DAZLess, no? As mentioned dun sa mnemonic natin. And then RTIs, gitna may vir, no? Protease ending navir, di ba? Entry inhibitors, no? And fluvirtide, tsaka si maraviroc, CCR5, okay? Si Mara ay ayaw mag-attach, okay? Ay, meron pa yan. Si Mara ay ayaw mag-attach sa CR, okay? Ayaw mag-attach sa CR. Okay? So yan. So Mara for CCR5 receptor antagonist and fluvirtide, di ba si GP41 to prevent the fusion of the cell to the virus, okay? And integrase, grace, no? Grace for gravir, all right? Your integrase inhibitors. So yan yung mga drugs natin. All right? So okay. Naunahan ko pala, no? Sinulat ko lahat kanina doon. So yan yung aking slides. And then yung dolutegravir, integrase inhibitor. Okay, next. We now go to our anti-protozoal drugs. Okay? Yung anti-protozoal drugs natin, simulan natin sa malaria. Okay? So, for malaria, actually, kailangan nating malaman kasi kung nasaan ba yung organism ba. Nasa tissue ba siya, particularly dun sa liver, no? Or nasa bloodstream ba siya? Bloodstream? Bloodstream ba siya, no? Pag nasa tissue siya, okay, pag nasa tissue siya, you give your tissue schizonticides, no? And napaka, tongue twister nito. Tissue schizonticides, and then you have your blood schizonticides, no, which kills the malarial or the parasite in the blood. Okay, so pag tissue schizonticides, pumapatay siya dun sa liver, no, particularly yung primaquine and your atovaquone, no, and important ito for malarial species na merong hypnozoid stage, no? Hypnozoid meaning ito yung sleeping stage nila. Hypno, 'di ba? Sounds like sleep, no? It's another term for sleep, no? Hypno, no? Yun yung time na nagsi-stay sila doon sa liver or nag-hide sila doon sa liver for para hindi sila makuha or mapatay, no? Nung drug natin. Okay? So those are your tissue schizonticides. Pag blood schizonticides naman, no? Pinapatay niya yung parasite natin or in the parasitic form na nandun siya sa mga red blood cells. Doon siya nakatira. Ibig sabihin, nandun siya sa bloodstream natin. So you kill it using your blood schizonticides. So let's go through them one by one. No? Okay. So, first, in studying your anti-malarials, you ask yourselves first kung yung organism ba ay sensitive or resistant to chloroquine. Siyempre, if kapag ito ay sensitive to chloroquine, no? What you give is chloroquine kasi it's the best drug, no, for treatment and prophylaxis of malaria, no, for those na walang chloroquine resistant. Pero if it's resistant, okay, ang tanong natin, are you giving it for treatment? Okay, yung anti-malarial natin, or are you giving it for prophylaxis? So if you, for example, if you're treating, okay, if you're treating the person for malaria, no, you can give your quinine. No, you can give your quinine. Kasi your quinine is given for the treatment of your chloroquine resistant, no? Dito yung mga resistant, no? It's given for your chloroquine resistant microorganisms, or malarial species, no? Chloroquine resistant malarial species. Or you can also give your atovaquone proguanil, no? Or lumefantrine. So again, ang given for your chloroquine resistant, you have your quinine, your atovaquone, no? Proguanil, and your lumefantrine. Yun yung tatlo na ibibigay mo if the patient has chloroquine resistance, no? So again, quinine, atovaquone, proguanil, and your lumefantrine. Okay? if you are giving it for prophylaxis, no, the main drug that you can give is your mefloquine, no? Mefloquine is for so ito treatment, di ba? Ito ay prophylaxis, no? Prophylaxis for your malaria, no? It's given also your atovaquone proguanil can also be given as a prophylaxis for your chloroquine resistant agents. So again, tatanungin natin kung chloroquine resistant. Pag resistant, ay pag sensitive, you give chloroquine. Pagka resistant, you give quinine and the other drugs that were mentioned before for treatment. Pagka prophylaxis, you can give your mefloquine. Okay? So yan yung mga yan yung ating mga drugs na initial drugs or the main drugs used for your malarial species. Now, if the malarial species has an extra erythrocytic form, no, meaning kaya niya magtago dun sa RBC, no, hindi lang siya nagtatago sa RBC, I mean, no, pwede siyang makatago dun sa liver natin or yung ating tinatawag na exoerythrocytic stages, no, particularly seen in your VVAX and ovale. Okay, VVAX and ovale, you now give your primaquine. All right? So that is given for the stages na wala sa bloodstream natin. So your primaquine is the main drug for that. So again, chloroquine for sensitive, quinine, atovaquone, proguanil, and lumefantrine for treatment, no, ng resistant, mefloquine and atovaquone, proguanil for prophylaxis, and if meron siyang exoerythrocytic stage or meaning meron siyang hypnozoites, no, na pwede magtago sa liver, you give your primaquine. Okay, you give your primaquine. Okay? And other drugs, no, na ginagamit for our for our malarial species, no, is your sulfadoxine pyrimethamine, no. As you can see dun sa pangalan niya, it's a sulfa drug, no. Para siyang anti-metabolite din kanina, no. It inhibits yung folic acid synthesis natin, yung ang tawag dito, yung dihydrofolate reductase and dihydropteroate synthetase. Okay? So those are the enzyme inhibited by your sulfadoxine pyrimethamine. Your doxycycline, that is a tetracycline, no, can also be given as a chemoprophylaxis for your drugs for your malarial species na multi-drug resistant. Okay? Multi-drug resistant. Okay? So doxycycline for multi-drug resistance. Again, doxycycline is a tetracycline, so it can also chelate your calcium, no? Hence, no, not given sila for patients na, for example, pregnant women, or hindi mo din siya tinitake with milk kasi mataas yung calcium nun, no? Bababa yung absorption ng doxycycline natin. Okay? So your halofantrine and your lumefantrine, you can give it again for patients na may chloroquine resistance. Diba? Sabi ko sa inyo yung flow ng thought process doon. Tanungin mo muna if it's resistant or sensitive. Okay? Pag sensitive siya, you give chloroquine. Pag resistant siya, pwede mong ibigay yung mga drugs kanina, 'di ba? Your kasama doon yung lumefantrine na nabanggit ko, si atovaquone and proguanil. Okay? So yun yung mga drugs for that. So hence, yung halofantrine and lumefantrine, ginagamit siya for chloroquine resistant malarial species. Okay? Yung next is your artemether and lumefantrine naman, no? Your artemether and lumefantrine, pwede siyang gamitin for uncomplicated falciparum malaria, no? Uncomplicated falciparum malaria in the Philippines. Okay? So it's sold in the brand name na Coartem. Alright? So yan yung ating mga anti-malarial agents natin. Alright. And lastly, we go to our anthelmintic drugs, no? Yung anthelmintic drugs natin. So actually, you can classify them into, kailangan mo munang alam kung ano yung tinitreat natin. No? You have your flatworms and your roundworms. Pagka, ano tawag dito? Pagka roundworms, such as your nematodes, actually, the main drug that is used for that is albendazole. No? Siya yung main na ginagamit for roundworms. Pero meron lang mga certain drugs na parang kailangan yung matandaan that are used for certain organism. Kunwari, si diethylcarbamazine, this can be given for filariasis, no? Filariasis. filariasis, no? Ito yung elephantiasis, di ba? No? Caused by your Wuchereria bancrofti and your Brugia malayi, di ba? So itong dalawang to, it can cause filariasis. And ang, di ba, yung elephantiasis, lumalaki yung mga binti nila, di ba? So ang palatandaan ko, di ba, parang elephant, okay? Elephant deck, okay? Elephant deck for diethyl carbamazine. All right? So diethyl carbamazine, elephant deck. Okay, next. So next is your ivermectin. Your ivermectin, no, is given for onchocerca. Onchocerca infections. Your onchocerca volvulus is also known as your river blindness, no? River blindness. And ang palatandaan ko diyan, river, no? Sounds like river mectin, no? River mectin. So that is for your ivermectin. All right? Okay, and next we have your pyrantel pamoate. Yung pyrantel pamoate, pwede rin siya for ascariasis, mga hookworms, and your pinworms. No, it's an alternative for that. No, pero it can cause or it is contraindicated in patients na may mga hepatic dysfunction. Okay, as a general rule, pag nematodes, no, the main thing that you have to remember is pag nematode siya, safe to answer actually albendazole. No? Pag kunwari wala ka ng maalala, except si mebendazole, which is given for your whipworms. No? Ang palatandaan ko dun is whip me. Okay? Whip me. Okay? Whip me. Me for mebendazole. Whip for whipworm. Okay? And your thiabendazole for trichinella. So, ang trichinella, no? Thiabendazole, yung trichinella kasi, isa siyang organism or isa siyang bulate na nakuha mo sa pork and pumapasok siya sa mga muscles, no? And pag sinulat mo siya, di ba? T for trichinella and then T for thiabendazole. Parang yung emoji na umiiyak, no? So umiiyak ka dahil sobrang sakit dahil pumapasok siya doon sa muscles natin. All right? So those are your drugs against your nematodes. Sorry, inuna ko yung nematodes kasi mas madali siyang aralin, no? Pero pagka drugs against nematodes, trematodes and cestodes naman, most of the time ang answer dyan would be praziquantel or your niclosamide din, okay? Itong dalawang to, no? Si praziquantel, ang ginagawa nito, no? Mechanism of action na it increases yung permeability, okay? Permeability to calcium. Okay? Therefore, pag pumasok si calcium, para magko-contract siya, para siyang mas stimulate, no? Dahil tuloy-tuloy yung stimulation ng muscles dahil madaming calcium, no? Si worm ay mapaparalyze, hindi na siya gagalaw. Okay, hindi na siya gagalaw. So ang palatandaan ko diyan is praziqualcium. Qualcium. All right? So that's praziquantel. And your niclosamide, no? Niclosamide is also used for cestode infections. Kunwari yung mga tainya, mga Diphyllobotrium latum infections. And ang ginagawa nito is uncouples yung oxidative phosphorylation niya, no? By activating yung mga ATPases natin. So ATPases. So ang mnemonic dito, si Nico ay madaming energy. So ATP, no, niclosamides. All right? So those are your drugs against your different helminths, no? So I think that's the end of our pharmacology lecture, no? At this point, no, I think medyo saturated na rin yung mind natin, no? Pero I hope you power through in finishing everything pa, no? Alam ko onti na lang din yung time before the board exam and most of you kakatapos lang din ng internship. Shout out din sa mga naging interns ko before sa PGH, no? Ayan, so I hope you're doing well then, no? And pharma is really a hard topic to anong tawag dito, to memorize and to understand. Pero the key to having a higher grade in pharmacology is to see kung ano yung mga patterns, no? Very important talaga sa akin yung nakikita ko yung ano yung mga common denominator between the different drug classes, kung ano yung mga pare-pareho dun sa pangalan nila kasi ako man hindi ko ma-memorize lahat 'yan, no? So, and very important sa akin kung napansin ninyo na yung picture natin, no, yung mga lectures ko, mas visual siya. I don't put a lot of words on it kasi gusto ko na makita mo siya, ma-classify mo siya, saan siya underneath, saan siya anong type of drug class siya. And the moment na master mo kung anong drug class siya, ano yung mas madali mong malaman kung ano yung mechanism of actions nila, ano yung mga side effects na associated sa kanila. Okay? Ang goal ko, no, by the end of I hope na by the end of the week na mag-aaral kayo ng pharmacology, no, makagawa kayo ng sarili ninyong mga parang drug charts, no, na nandyan lahat, no. Naalala ko before no natapos ko yung pharma boards, no, meron akong may notebook lang ako na dedicated for that, no, na lahat sila parang overview of everything. May drug classes lang ako. Parang yung mga dun sa for example, ito. Yan. Yung mga nandun sa handouts niyo, gawa kayo ng sarili ninyong ganun, no? And hindi lang drugs yung ilagay niyo. Ilagay niyo din yung mga important side effects, pero puro keywords lang, no? Para once nag-review kayo ng pharma, andun lahat, one big picture. So pwede kayong bumili. Dati bumili din ako ng big anong tawag dito? Big na drawing book, yung malaking ganyan, no? Para kitang-kita ko everything doon, no? Pero syempre, it depends pa rin sa inyo kung ano yung anong tawag dito? Ano yung best way for you to learn. But at the end of the day, no, the best way to recall everything is yung tinatawag nating spaced repetition, no? And yung active recall. Kailangan nyo paulit-ulit i-test yung sarili nyo, no? Mas madaming questions, no, about these drugs, mas mataas yung recall. Okay? So that's how you put things in the long-term memory, no? And hindi lang siya parang minsanan mo lang babasahin. Hindi ganoon ang pharmacology, no? Kailangan mo siyang ulit-ulitin. Hindi babasahin na, kailangan ulit-ulitin mong ma-retrieve sa memory mo by testing yourself a lot of times. So do your flashcards, do yung mga question and answers, ganyan. Mas maaalala nyo sila the way by doing that way, no, rather than just reading. Okay? So I really advise not to just read, no. You test yourself. You test yourself more frequently. All right? Sige, yun lang. I hope you do well and I would see you around as colleagues once you get the that license na, no, that MD, and hopefully makita ko kayo everywhere anywhere, no, kung saan man kayo mag-practice. All right, sige, I'll see. Thank you for giving me the opportunity then to teach you again, and good luck, and I'll pray for you guys. All right, bye bye.